That seems good to me. So I will go ahead and introduce myself. Thank you all for being here today, and many thanks to our speakers, who I will introduce shortly. My name is Ellen Hostetler. I'm from the John Ritter Research, I used to be from the John Ritter Research Program. I'm from the John Ritter Foundation for Aortic Health. Muscle memory there. Many of you probably know me from my old role there, and I'm really pleased to be hosting this webinar with my friend Chrisanne, who is here from GADA Canada. And I'm also super pleased that we have two wonderful speakers joining us who will be covering topics of reproductive health, family planning, pregnancy, as it relates to thoracic aortic aneurysm and dissection, which is a topic we know a lot of you have had many questions about. I will go ahead and say a little bit about the foundation in case you don't know us. We are a nonprofit based in the United States. We support patients and families with thoracic aortic aneurysm and dissection, and we fund research, do patient education through webinars like this, but also in person. And we also have a peer support program. So we have lots of activities. So please come to our website, sign up for our newsletter, follow us on socials, and we'd love for you to be a part of our community. Even if you are based in Canada, of course, you have great GADA in your backyard, but we'd also be happy to have you be in our community also. Chrisanne, I'll let you go ahead and introduce GADA.
Yes, thanks, Ellen. It's always a pleasure to co-host a webinar with you. I'd just like to quickly remind everyone that GADA Canada is a patient advocacy organization in Canada. We've been in existence for the last 37 years, supporting research and education for genetic aortic disorders. We were formerly known as the Canadian Marfan Association. Our association has been funding research for over 20 years now, but I just wanted to point out one of the recent research studies we funded was to identify risk factors in thoracic aortic dissections during and after pregnancy, which actually pointed out very interestingly the importance of knowing the family history and genetic diagnosis of a thoracic aortic dissection to allow early identification and increased follow-up in order to prevent death in pregnancy. Another research that we fund is the Montalcino Aortic Consortium, and I bring it up here because it's a very important patient registry for genetic aortic disorders. For anyone who's had an aortic dissection with a family history of aortic dissection and a genetic diagnosis for it. This registry is one of the largest aortic registries that helps experts in the field to look at genetic aortic disorders and compare them and then come up with the guidelines for management of these disorders. If anyone's interested in MAC research or the Montalcino aortic research, please contact the GADA or the JRF with any questions or for enrollment. So it is a privilege today to have with us Dr. Sara Thorne. Dr. Thorne is an obstetric cardiologist in the Adult Congenital Heart Disease Program in Toronto. Before joining Toronto for 20 years, she practiced at the University Hospital Birmingham, where she established the Regional Adult Congenital Heart Disease Unit and a obstetric cardiology program in Birmingham Women's and Children's Hospital. She has her areas of expertise are cardiac disease and pregnancy, aortopathy, and just general adult congenital heart disease. It is also a privilege to have Dr. Thorne on the professional advisory board for GADA Canada to reach out for her great expertise in situations where we need her help. So welcome, Dr. Thorne, and thank you for giving us your time today to give a talk.
And I will just introduce our other speaker today, Gretchen MacCarrick. Gretchen is a board-certified genetic counselor in the Department of Genetic Medicine at Johns Hopkins and has worked in cardiovascular connective tissue clinics since 2001, both in patient care as well as clinical research. And she's also the co-founder of the Loeys-Dietz Syndrome Foundation and a member of the professional advisory board of the Marfan Foundation. Many of you know her. Whenever we do any post with her, people always comment how much they love her and how much she's helped her. She's been a part of this community for such a long time. And we're also happy to have, at the foundation, worked with her last year to develop a mental health book for people with thoracic aortic disease. So she is the co-author of that book. It's free. I'm going to put a link to it, that if any of you would like to download a copy of that via PDF, please do so. And if you need a hard copy for someone who can't access the electronic version, please go ahead and email me, and we'd be happy to send you that as well. And I think that this disclaimer, just please take a moment to read this. But the information that's being provided here today is with the understanding that this is an educational webinar, that you should not make medical decisions or change your medical care based on information that you learn. So we hope that you take what you learned today and you bring it to your aortic care team or your medical providers. If you have questions, you please feel free to follow up with either Christiane or myself, and we can hopefully get either Dr. Thorne or Gretchen to weigh in on those questions that we don't get to. And with that, I think we're about ready to get started. The Q&A and chat, please go ahead and use those buttons. I think hopefully by now, many of us are familiar with Zoom, but if you're not, those buttons below will allow you to ask a question. You can ask anonymously also, and always be respectful in the chat with others. And then last, here's our contact information. This webinar is being recorded, so you will have the link so that you can share with other interested parties that you might know, or rewatch if you'd like to go over the information again. And with that, I will stop sharing and leave it to Dr. Thorne to take us through the first part of today's presentation.
So good afternoon. Thank you so much for your invitation. My first question to you is, can you see my screen?
We
Yes,
can. We see not the presentation view though.
Yeah, I'll go on to presentation.
Okay, beautiful. Yes, that's perfect.
Yes, it's perfect.
Wonderful.
Thank you. So thank you so much for this kind invitation. It's a real privilege to talk to you all. This is an area that I know Gretchen and I feel very strongly about, and I hope that you'll find this helpful, and I hope that we'll be able to answer most of your questions as well. I have no disclosures. The objectives that I'm going to talk about during this afternoon's talk are to consider the risks of pregnancy and aortic dissection, to think about pre-pregnancy counselling, to think about medications for aortic disease and contraception, to consider the role of surgical intervention before pregnancy, and then how we would propose caring for somebody with aortic disease through pregnancy and afterwards. So who do we think is at risk? And there are many conditions where we're concerned about the aorta. Some carry a higher risk than others. Many of them are genetic, and these are the main conditions that we would be considering. So bicuspid aortic valve with aortopathy, that's going to be the commonest reason for somebody having a dilated aorta, but probably the lowest risk. And then the syndromic conditions like Marfan syndrome, Loeys-Dietz syndrome, vascular Ehlers-Danlos and Turner syndrome, and then the non-syndromic hereditary aortopathies, about which really we're learning a lot, and that are a little bit newer kids on the block, if you like, in terms of how to care for people. So let's just think about pregnancy and what it demands our hearts and our cardiovascular system to do. You'll see along the bottom line, this is the time through pregnancy, through the first trimester, the second trimester, the third trimester, around the time of giving birth, and then out into the postpartum period. Going up on the y-axis is the percentage increase in the things that we're measuring, and I'd like you to look at the red line. The red line is the percentage increase in cardiac output. That's how much blood your heart has to pump out every minute. And it increases by about 50% quite early on in the pregnancy. So this is a marathon rather than a sprint. And that increase is significantly higher when the baby's born, whether by cesarean section or by vaginal birth. And then it gradually decreases after pregnancy. We need to think as well then that the stresses on the aorta are partly a shear stress as a result of this increase in cardiac output, but also to understand that the hormonal changes of pregnancy, particularly the rise in progesterone, softens all our tissues so they become stretchy to accommodate the baby, but that includes the aorta. So the tissues of the aorta will also be softer, if you like. So let's ask some really basic questions. Is pregnancy-related aortic dissection common? Because it's a really scary thing to think about, and we do need to know how often it happens and what are the outcomes. So it is a rare thing to happen. However, most dissections in women of childbearing age do occur in relation to pregnancy. And if you look at deaths in pregnancy amongst the mother in high-income countries, the commonest cause of death is some sort of cardiac condition. So that's 1 in 5 deaths are due to cardiovascular problems. And 10% of those are due to aortic dissection. So if we look at death, which thankfully in pregnancy in high-income countries is rare, there's a small but significant number of these are due to aortic dissection. There are some key points to think about. So one is that most women who die with an aortic dissection in pregnancy were not previously known to have an aortopathy before their pregnancy. And the issue here is that delays in making the diagnosis contribute towards death. The more quickly you can make a diagnosis of dissection, the more likely you are to have a good outcome. And so if you're known to have an aortopathy, like I think all of us are in this meeting, you have a better chance both of avoiding dissection because you should be able to access the best care. But if you do have a dissection, you have a better chance of having an early diagnosis and early surgery. A lot of the data that we have relate to people with Marfan syndrome, and that's because it's a condition that's so well known, and therefore we have more information. And certainly we know for people with Marfan syndrome who have a pregnancy-related dissection, 2/3 of those are type A dissections, so that's involving the ascending aorta. 2/3 happen after the baby is born, and the median is about a week after the baby is born. Of those who occur during pregnancy, it tends to be later in pregnancy and into the 3rd trimester that aortic dissection occurs. I hope this lets us think already that pre-pregnancy counselling and a good pregnancy heart team are really important, because if we know everything, if we know before somebody becomes pregnant what their aortic condition is, we're likely to mitigate the risk of dissection or a poor outcome. And the point for pre-pregnancy counselling for anybody is to educate and empower women from their teenage years onwards to be able to make decisions about their own fertility. And this has to include access to contraception so that they have control. It also means that we should assess and optimize their general cardiac and general health before pregnancy. And then we can counsel women about the risks to them, the risk to their baby, and whether there are any obstetric risks that relate to their aortic condition. We should review medication that could damage the fetus, that's teratogenic medication, and plan when to make changes there, and make initial plans for who should look after you, how often you should be seen, where you should be seen, and how maybe you would consider giving birth. And the pregnancy heart team can be quite a big team with mum and baby at the middle, but a big team are involved. And in people with aortic disease, then we need to bring in the aortic team as well. So I'm going to talk a little bit about contraception because it's such a key part of planning what you're going to do with the pregnancy. And women with aortopathy need the same autonomy over their fertility that everybody else does, not just for personal and socioeconomic reasons, but also to time or prevent a pregnancy may be life-saving. In terms of choice, the bottom line is there's no aortic contraindication to using any method of contraception, and therefore we need to consider the woman's personal preference, individualize the risk, and really important, think how effective the contraceptive method is that's being chosen. So just to run through, barrier methods we're all familiar with. There are no cardiac contraindications to using barrier methods, and they protect against sexually transmitted disease, so that's all good. But clearly they are a bit operator dependent, and therefore the efficacy could be variable. So what about the pills? Two basic sorts of pills. One is a combined estrogen and progestogen pill, which, as long as you remember to take it, has really good efficacy, and it works by preventing ovulation. There are also progestogen-only pills, and there are two basic sorts. The standard mini pill, of which there are many, does not prevent ovulation. It makes the cervical mucus hostile to sperm, and it's a nice method of contraception, but it is less effective than a method that will prevent the egg being produced. There is a newer progestogen-only pill. The trade name is Slind. It's drospirenone, and this is more effective than the other standard progestogen-only pill because it also prevents ovulation. The issue with estrogen is it's prothrombotic, and that means it increases the risk of blood clots. Now, an aortopathy itself doesn't have an increased risk of blood clots, but other related conditions may. So if you're a woman with an aortopathy who also has, for example, a mechanical heart valve, heart rhythm problems, coronary disease, high blood pressure, or even something like migraine, these people should avoid estrogen and go for one of the progestogen-only methods. There are also long-acting progestogen-only methods. There's a 3-monthly Depo-Provera injection, an IUD, which could be Mirena, Jadis, or Kyleena, and then a newer subdermal implant called Nexplanon. And of these, the IUD and the Nexplanon are really efficient, and they give equivalent efficiency in terms of preventing pregnancy as does sterilization, with the advantage, of course, is that it's completely reversible. The only hypothetical thing to be aware of with these methods is for women with vascular Ehlers-Danlos loss, that one would have to be careful inserting an IUD because of the risk of causing damage and rupture. I think that's a hypothetical of the uterus. I think that's a hypothetical risk, but it is one just to be aware of. So if I see a woman for pre-pregnancy counselling, the first thing to understand is what is her desire for a pregnancy, because not all women want to have a pregnancy when they come for counselling. If they do, what's the timing that they would like to consider a pregnancy over? What contraception is being used? And really importantly, are they already pregnant? And that is not an uncommon thing for us to find. Having considered all those things, a key thing for us to find out is, do we have a genetic diagnosis? Do we have genetic confirmation of this condition? And that's really important, both for considering what the risk is for the woman, but also because there may then be an option for pre-implantation genetic diagnosis. And that's something that Gretchen is going to talk about in more detail in her talk. If we know what the mutation is that's causing the aortopathy, is it a particular high-risk one? And really importantly, what's the family history? How does this condition manifest in the family? If there's dissections in the family, what age did they occur at? Do we know how big the aorta was? Were any of those dissections in relation to a pregnancy? Because those factors will really help us understand and individualize the risk. And then for the woman herself, we want to know are the aortic dimensions stable? Have they been the same size? Has it been the same size for many years? And do we have up-to-date imaging? And if we know that, for example, that the aorta is getting progressively bigger, then this is potentially going to be higher risk compared to an aorta that's been the same size for a long time. We have to think about the general heart status, because some of these conditions can be associated with weaker heart muscles, so impaired left ventricular function. And some of these conditions can be associated with abnormal mitral and aortic valve function. And that would also potentially increase the risk of a pregnancy independently of the aortopathy. And then importantly, we need to consider medication. Many people with aortopathies are taking angiotensin II receptor blockers like losartan or candesartan, or a beta blocker, and some may also be on a statin. So we need to think about these medications. And then we need to have a discussion of the risk. Clearly, the big thing that we're going to be worried about is whether aortic dissection is likely in a pregnancy. And if we think that the risk is significant, we then have to consider whether it might be reduced by having pre-pregnancy elective aortic surgery. We need to understand that the risk is increased towards the end of pregnancy and in the post-birth period, and also to discuss if you had that severe pain in your chest or your back, what you should do. Risks are always additive, and so we have to add in the risks of any other cardiac issues and any other unrelated medical or lifestyle issues that could increase the risk of a pregnancy. If we have a known genetic inherited aortic disease, then the recurrence in the baby, the rate is likely to be 50%. And therefore, we'll have a discussion about whether there's a role for preimplantation genetic diagnosis. The risks to the baby can also involve maternal drugs, and obviously as well, if the mum dissects during pregnancy, we need to think about what that means for the risk to the baby. So I'm afraid this is a slightly busy slide. This is from the European Society of Cardiology guidelines for the management of pregnancy in women with cardiovascular disease. And basically it's from yellow to bright red is how I think the risks will increase, the risks of pregnancy will increase in these different situations. So for example, somebody with a bicuspid aortic valve whose aortic size is less than 45 millimeters, this is a relatively low risk condition. And these women should be seen maybe every couple of months with an echo in a referral center, but not necessarily an expert surgical center. The next level of risk up would include people with Marfan syndrome and other hereditary thoracic aortic diseases with an aortic dimension between 40 and 45. A higher risk in these conditions with a diameter of more than 45, and super high risk will be any woman who has had a previous dissection and has residually dissected aorta. And as the risk goes up, then so does the need to be seen in an expert surgical center, and so does the frequency at which we might review somebody. And for these in the highest risk groups, we should consider whether the risk of pregnancy would be mitigated by pre-pregnancy surgical repair. So who should have prophylactic surgery before their pregnancy? And this is from the American Heart Association guidelines produced just last year. And there are some, and there's the green, orange, and yellow are sort of levels of strength of recommendation, if you like. So for example, a woman with Marfan syndrome or of one of the non-syndromic thoracic aortic diseases whose aorta is more than 4.5 centimeters, we would recommend surgery before they undergo pregnancy. For somebody with the less risky condition of bicuspid aortic valve, we'd say more than 5 centimeters. And then this is where the actual mutation that is found comes into play. If you have Loeys-Dietz syndrome and you have one of the higher risk mutations like TGF beta receptor 1, 2, or SMAD3, we would recommend surgery if the aorta is more than 4 centimeters, more than 4.5 centimeters with one of the lower risk mutations, as you can see here. For all of these are just numbers and they're guides. For anybody who has what we would call risk factors, and that for me is somebody whose aortic dimensions are not stable, so the aorta is clearly growing, or there's a family history of aortic dissection, that threshold for intervening before pregnancy is probably going to reduce. This statement about the non-syndromic hereditary thoracic aortic diseases of saying more than 4.5 centimeters really reflects a lack of available data. And we know that there are some mutations where we would recommend surgery at a lower diameter than 4.5 centimeters. So let's think a little bit about specific conditions. So Marfan syndrome, this is the condition for which we have the most data. We've known about it for a longer time. It's relatively common. And people with Marfan syndrome, you can spot somebody with Marfan syndrome on the bus, on the train, and on the public transport. And so it's an easier diagnosis to make than for the non-syndromic conditions where you can't tell from looking at somebody that they may have a fragile aorta. For Loeys-Dietz syndrome, this was only described in 2006, and I think for sure there are still a lot of people around who may have been misdiagnosed as having Marfan syndrome or may not have been diagnosed. The risk in pregnancy is probably similar to Marfan syndrome. For women with non-syndromic hereditary thoracic aortic disease, we don't have syndromic features to awareness, and therefore probably there's a low level of diagnosis. And this is where it's absolutely crucial to pay attention to family history. And it's really important that if a family member has an aortic dissection below the age of, say, 50, that the family is screened, that patient is screened for one of these conditions. And if their screening is positive, then it allows the family to be screened. For example, if we consider the ACTA2 mutation, the advice given is that we should manage somebody with an ACTA2 mutation like someone with Marfan syndrome. There was a small study of women with ACTA2 mutations, and 6% had a dissection. That's a lot, but there were no dissections in women who'd already been diagnosed, and several people who dissected without having been diagnosed had a family history of dissection. And that tells us what I've already said, that if you know you've got a diagnosis, if you know your diagnosis, you have a much better chance of not having a dissection. If you have a family history, it's really important to get screened to see if you also have the same condition. Moving on to vascular Ehlers-Danlos syndrome, this is really rare, but it's probably the highest risk condition. And depending on the studies that you look at, the chance of a woman dying in pregnancy because of her vascular Ehlers-Danlos syndrome could be as high as 30%. And certainly we think probably 50% of women will have severe morbidities. So that would be a bad complication that did not result in their death. And that might be dissection of an artery, rupture of a hollow organ, so that could be bowel or it could be the uterus. And then probably the commonest is severe hemorrhage and severe tearing at the time of birth. So these are the women who are at the highest risk, not necessarily because they have an aortic dissection, but because all of their tissues are so fragile and at risk of rupturing. What about pregnancy risk of medication in aortopathy? So one of the commonest medications for women to take are the angiotensin II receptor blockers like valsartan, candesartan, losartan. These are contraindicated in pregnancy because they cause birth defects. They're also secreted in breast milk, and we don't know what effect that can have on the baby. And the recommendation, therefore, is to avoid these medications during pregnancy and during breastfeeding. We have an alternative, which is to take a beta blocker, for example, bisoprolol or metoprolol. These are considered safe in pregnancy and for breastfeeding. There is data on some of the older beta blockers like atenolol that show a possible small growth restriction effect for the baby in people taking high doses. We don't see it really in women on bisoprolol and metoprolol, and we do consider these drugs to be safe. There's some research now that suggests that statins like rosuvastatin or atorvastatin can have a protective effect for the aorta. These again, so some women may be taking these as well. These again are contraindicated in pregnancy because it can cause birth defects. And again, they're secreted in breast milk, and we don't know the effects that might have on the baby. So the advice is to avoid them. The difficult question is to decide when to change the medication. So you could say, I'm coming off my ARB now, and I'll just take a beta blocker, and I will then start to try and conceive. But it may take more than a year to conceive, in which case you've been denied a useful drug for that year before conception. So an alternative is to stop any contraindicated medication as soon as pregnancy is confirmed. And this is something that you should individualize and discuss with the people, the doctors looking after you. So what about prenatal care? We're pregnant, we're going to change our medication to a beta blocker. We'll have a plan in place in case symptoms of a dissection occur, and we'll have a plan for the frequency and place of review. For anybody except with the lowest risk conditions, this probably should be with an expert pregnancy heart team and in a centre that has aortic surgery on site. For women who don't have high risk features, I would see somebody at least every trimester with an echocardiogram. For somebody who has any high risk features, I'd review monthly with an echo. And if there are any concerns about the part of the aorta you can't see well on echo, I would do a non-contrast MRI. MRI is safe in pregnancy. We would do it without gadolinium. That's the contrast agent that we usually use. Not because we know that gadolinium is unsafe, but because we don't have the information. We do know that MRI is safe. We always try and avoid doing tests in the first trimester when the embryo is forming. And it's also kind of nicer if you're going to have an MRI scan to have it before you're sort of 38 weeks, and it's very difficult to fit in the scanner comfortably. So a sort of second trimester scan is often the best time. But if there's any concerns, the scan should just be done. And if there's a concern about dissection, then a CT scan has radiation involved with it, but it absolutely would be the right thing to do. What about giving birth? Some women have been told they should only have a cesarean section. I don't think for most women that's not the case. We need to consider how to reduce the pain response and the stress on the aorta, and the best way to do that is with good regional analgesia, so spinal epidural. Probably the lowest cardiovascular stress for giving birth is to use regional analgesia, let the baby's head descend right to the perineum, and then lift the baby out with forceps so the woman doesn't have to push and she doesn't have to have pain. That can also compare with a cesarean section. As a cardiologist, I would never suggest strongly how a woman should give birth, because I think that's between you and your obstetrician, and it depends partly on your choice. It depends partly on the risk of your aorta. And then it also depends partly on the expertise of your obstetrician. And it's a discussion that you should have within your own unit. Once the baby's out, it's not all over. And we know that we need early follow-up and aortic imaging. And we know that the woman needs to understand what to do if she has severe pain. Secure contraception is always part of the post-baby discussion. What are you going to plan to do after you've given birth? It's usually the last thing on anybody's mind, but it does need to be addressed. When we counsel somebody about pregnancy, there are alternatives to pregnancy. That might just be contraception. Some women might feel that the risk of pregnancy themselves is too high and may want to consider surrogacy. Now, surrogacy can be with your own eggs, in which case you have to go through an IVF process, which may include pre-implantation genetic diagnosis. And this will carry a reduced risk to the mother because the risk of having IVF if you have an aortopathy is relatively low. But it does carry still probably a small risk. Surrogacy with donor eggs, so somebody else's risk, carries no risk to the mother. And then, of course, adoption is also always an option. So to summary, pregnancy is possible for women with aortopathy with expert pregnancy heart team care. And with specialist counselling, using guidelines and then individualising the risk for each woman, she can make an informed decision about childbearing. Pregnancy risk can be reduced by pre-pregnancy aortic surgery for some women, and close expert care during pregnancy, birth, and the puerperium will reduce risk. Thank you very much. I've said questions, but I think you might be going to save questions for the end of our meeting. Thank you. Can you stop my screen sharing for me? Here we go.
You're clear. Thank you. Thank you so much for that presentation. Yes, we will hold the questions to the end if you all don't mind, and let Gretchen go ahead and share her presentation.
I've lost my ability to, oh, there we go, share screen. Sorry, we're good. Thanks. Okay, thank you for that excellent talk from Dr. Thorne. We're going to kind of pivot a little bit to really focus a bit more, on pregnancy testing options if you're already pregnant or potentially using assisted reproduction technologies, kind of in, the decision-making process and kind of how to think about pregnancies, or help to have people in your family help them to think about pregnancies and kind of questions to ask themselves, and kind of how to be a good support for those family members who are thinking about this. It's a really complicated topic. And I would say that, when anyone is thinking about having a child, right, their genetic and health status is one small piece of the overall picture that people are thinking about. So remember that, even though we get really focused on a 50% risk of having a child with this genetic condition, there are other considerations in terms of life timing, finances, worldviews about bringing a child in that your family members are also considering, in addition to just having that genetic diagnosis in the family. And so I wanted to just have a brief slide because the reason we're here, obviously, is for people to think about genetic testing and pregnancy in the context of aortic dissection or their genetic condition. But there are other times around a pregnancy where you're going to have the option to access genetic testing. And so those can include carrier screening. So it is really routine standard of care now that any couple in the preconception or kind of early pregnancy stages gets offered carrier screening. So this is to look for DNA changes that either the mom carries one copy of, the dad carries one copy of, and if a baby gets both copies, they could be at risk of a recessive disorder. So kind of unrelated to the dominant aneurysm conditions, but many people have to make decisions about genetic testing for carrier screening. There might be age-related testing. Nowadays, even women in kind of their mid-30s are offered interventions or screening for things like Down syndrome or chromosomal disorders. There might be other family history. So there might be a history of a breast cancer gene or a sibling with a different condition where they might also have implications for genetic testing you can access in a pregnancy. There is a new technology called NIPT, or non-invasive prenatal testing. So this is also kind of a screening test for things like Down syndrome, where they actually take a blood sample from mom, and there are fetal cells circulating in mom's blood cells, and so they can look at the sex and the number of chromosomes that might be coming from the baby in the mom's blood cells. And it's usually followed up with other types of testing in pregnancy. And also there might be testing that if they do an ultrasound and there's any findings of a heart defect or a clubfoot on ultrasound, this might guide to more genetic testing in a pregnancy as well. There was this really interesting paper that came out in 2023 that actually queried or did focus groups with family members and individuals who are thinking about pregnancy and their partners. And there's a lot of different factors that families think about in terms of their genetic condition to help them think about pursuing prenatal testing or preimplantation genetic testing, which we'll get into. One is the thought process of the desire to have a healthy child. So again, we're back at this 50% risk of having a child at risk for hereditary thoracic aortic disease. But as you recall, there are also other risks. Each pregnancy outside of that risk has a 2 to 3% chance of intellectual disability or other birth defects. And so, even though we're focused on this, there could be other things that arise in a pregnancy that we just can't predict. Also, someone's lived experience really impacts their decision-making when it comes to pursuing a pregnancy or not. Not only their personal history, but what they have lived through in siblings or parents or grandparents, whether there was sudden death, whether there was a lot of eye problems or other issues related to the genetic condition, and also kind of what systems were really impacted in that family kind of impact that person's decision-making process about to pursue a pregnancy or not. Clearly, like Dr. Thorne talked about, there are a lot of pregnancy and postpartum risks that you as a family have to weigh the pros and cons of those risks to make a decision. Also, in consideration is variable expression of conditions. So in general, we would say that maybe a condition kind of runs a little bit true in families, but we definitely know that there's variability within a family. And if someone needed aortic surgery at 30, it could be that they have a child who needs aortic surgery at 15 or has more severe or less severe scoliosis. So there can be variability of how a condition presents itself, as well as sometimes disease perception varies over time. If someone is a 20-year-old woman versus a 35-year-old woman, whether they've been involved in a support group, whether they have had really personal experience with a lot of the variability, all of those things of how they view their condition can change over time. And so pregnancy views can also change over time. Someone's personal values would also impact their decision-making process, whether there is a responsibility that many people say, like, I don't want to pass this on. I don't want it to go on through my bloodline. Like, I feel a responsibility to stop it. Also, there can be ethical dilemmas, with any prenatal testing or even the preimplantation genetic diagnosis. This brings up questions of possible termination, which is emotionally charged, or potentially if you have excess embryos in a lab, what are you going to do with those embryos over time? Clearly, there are financial considerations. Even though we talk about all these different technologies, we are fully aware that there are different financial, legal, other barriers and obligations depending upon your country you're in, depending upon the state that you're in, that would impact your decision making. But most importantly, people really thought that their decision making was impacted by getting comprehensive, balanced, and timely information. So these are questions and conversations you should be having with your medical provider in plenty of time. So most of the technologies that we're going to discuss are dependent upon knowing your genetic variant. And we think that about, 30-ish% of patients with aortic aneurysm disease or risk for dissection know their variant, but there are many, many people who have a clearly familial predisposition where we don't know that gene change, and thus these technologies are just not available to you, unfortunately. So some of the things that we think about and that we actually begin talking to kids about fairly earlier, like Dr. Thorne was saying, in the teenage years, there's a whole bunch of options, including not having children, adoption, testing embryos and trying to do in vitro fertilization with embryos that aren't impacted, adoption, testing babies after birth. It's really worthwhile just having these really broad conversations and starting good communication within the family at early ages. And also knowing that everyone makes different decisions. So mom and dad and child and in-laws might have very different opinions. So being respectful and open is really key to get everyone together. So the first type of testing that is available in a pregnancy is done at about 10 to 12-ish weeks. and it's called chorionic villus sampling. And this is where you are collecting placental samples either through a needle through the abdomen or through the cervix, and the baby is formed from the placenta, so you're testing the placental cells for that known family variant. The test that most people know about is a little bit later in pregnancy, about 16 to 18 weeks. So at this point, you know, many family members, friends would know that you are pregnant, so it can impact kind of how people view if they would possibly terminate. This testing, again, 16 to 18 weeks, under ultrasound guidance, you're putting in a needle, collecting amniotic fluid from the sac around the baby. This baby has sloughed off skin cells within that fluid, and you're testing those skin cells. So again, unfortunately, this is dependent upon different states, different countries, and kind of their regulations when it comes to outcomes of what you might do with this information. Some people choose these technologies just to be prepared to kind of have a delivery plan or want to deliver at a care center rather than at home with a midwife, or just to emotionally prepare. You know, some people might choose termination of a fetus that is impacted with a genetic variant. So we get this question a lot. You know, most women are getting their detailed ultrasounds at about 20 weeks of gestation. You know, some of these conditions like Loeys-Dietz syndrome might have a club foot, or might, you know, have other contractures that you might see, but really there's not going to be a lot of ultrasound findings that are going to tell you that the baby has the condition. And the same thing with the fetal echocardiogram. You know, there are some papers that case reports that say, you know, babies with some of these conditions can show aortic dilation on a fetal echo, so an echo on the baby in the womb. But I would say it's not something that you should hang your hat on, whether it's enlarged or not enlarged, to kind of predict the outcome for the baby in terms of being affected or not. And so the big technology that people think about is called preimplantation genetic testing, M for molecular. So you are looking for a DNA test. People also do this condition for aneuploidies, like chromosome aberrations like Down syndrome, but prenatal or preimplantation genetic testing, molecular diagnosis. So this is really the woman is going through the IVF process and getting shots and medications for her to ovulate. She's harvesting, or they're harvesting eggs from the mom. They're getting sperm samples from the dad. They are creating embryos in a lab. What you need to know is that this can take months. And even if you do PGT, you know, it takes a lot of prep work to develop the probe to look for this DNA change. So sometimes they want grandparents' samples to try to develop the probe so they can really be confident that they're able to find this genetic mutation in embryos. So egg, sperm come together. It's 1 cell, 2 cells, 4 cells, 8 cells. At around that 8-cell stage, they're able to remove a cell. And it's not like you're removing like an arm cell or anything. The baby just keeps replicating cells, so you're not doing any harm, and they're able to test that cell for the DNA variant causing aneurysm in the family. And then they can try to get pregnant with the embryos that are unaffected, or you could use this also with surrogacy. So if the woman is affected and you're going with someone who's carrying the pregnancy, you could try to get pregnant with embryos that way. What I would say is that, you know, it is a laborious process, and say like you get 10 embryos, it might be that 3 or 4 of them have other kind of non-healthy appearances or chromosome issues. So you're down to 6 embryos, and then maybe 3 of them are impacted with the gene change. So you're down to 3 embryos. And so it can be very time consuming, because sometimes you need to do multiple retrievals. And when you're trying to implant those embryos, the decision then is, do you go with 1 embryo? Do you go with multiple embryos and possible risk multiple gestations? Sometimes you can go through cycles and someone might not get pregnant, and that extends the time frame as well. So it sounds like a really great technology, and it's incredible to be able to avoid having a child with that condition, but it can be quite laborious. A very good quote from this article from a woman who went through it said that PGT can be emotionally and cognitively taxing. It adds to the strain of relationships and creates logistical and financial burdens. So just knowing that even though these technologies exist, whatever people may choose or may not choose can really be emotionally burdensome. And in fact, we know that this kind of decision making about pregnancy is typically not something that a couple makes like overnight, unless I guess they have a whoops pregnancy. But it really, on average, can take years for people to kind of think about what they want. What does a family look like? How do they believe in testing? How do they want to utilize testing? How do they get their team in place? This can be quite a long process. So really having open and good communication throughout the family is very important. So I would say from my experience, kind of working with teens and young adults kind of through the lifespan, is that we start talking about what a family looks like early and young. I think little girls get this, they all have their dolls and their families, and they get this picture kind of what a family and being a mom is like. And we really want to explore a lot of different options of fur babies and going out and doing things and seeing the world, and being a mom is awesome, but not being a mom is awesome. And just making sure that that child and teenager has a really broad view of what life could look like. And it's not always being a mom, right? Again, like Dr. Thorne said, having really open conversations about birth control at young ages can be very helpful. In pregnancy, we always want to review those medications. And I will say that, people get caught up a lot in numbers, right? Is there a 10% risk? Is it a 5% risk? What is the risk? And I think for people considering pregnancy, at the end of the day, the risk is 0 or 100, right? Like you could get through pregnancy and have no complications, or you could have a dissection, and you kind of have to be okay with that 0 to absolute different options. Like Dr. Thorne also said, preparation is key. Plan early, get a good team around you. Our job is to support you. And so we can help facilitate conversation and pros and cons, but we ultimately want to support you in whatever decision you and your family make. I would say it's very imperative to get on the same page with your partner. I've tried to facilitate a lot of different couples coming in because they're viewing risks and perceptions and desires very differently. So this is really, when thinking about decision making, a time where you might need to really consider couples therapy. There has to be consideration that if something tragic happens in that pregnancy, that other parent could be a single parent. And it's uncomfortable to talk about, but it could be a reality. And so having those very honest, frank conversations is really key. A non-decision is a decision. And I think at the end of the day, people just have to feel confident with the decision that they make and not like continually second guess. And what I would say also is that everyone has a different story. We have women who have dissected in their first pregnancy. We have women who have had 4 pregnancies and no problem. And so it is awesome to really have community and hear different stories and advice, but also know that everyone's story is going to be different. And ultimately you have to feel very confident in the decision that you're making based on your history and your family values. So hopefully I left some time for questions. That was kind of a wham bam lecture through decision making and technologies, but I will open it up for questions then. Thanks, Ellen and Chrisanne.
Thank you, Gretchen. Maybe we can rapid fire try to get some questions in the last few minutes here, if you all are game. Chrisanne, do you want to start us off?
Yes, thanks, Gretchen, and thanks, Dr. Thorne. Those were very informational presentations. I think I might have to go back and listen to them again. But just to shoot off some of the questions that came in, firstly, Dr. Thorne, there's a question here asking about, is IVF genetic embryo screening for a known genetic disorder in Canada covered by public health system in Canada, or is it something that we have to pay privately?
So there's a mixed answer to that. Okay. Some aspects of it are covered and some are not. So it does still cost, and your geneticist is the person who will be the gatekeeper, if you like, to that. And I would imagine the costs may be different depending on which province you're in. but certainly some aspects are covered. Gretchen, I don't know if you have any view on that, but some aspects are covered.
Right.
Yeah, I think it's hard. It's insurance dependent, but I also think at least payers in the United States are also becoming more helpful and aware of this technology in addition to the IVF. And so we're getting more and more coverage. But again, it's copays and deductibles, at least in the US. So it's like completely insurance independent.
Yeah. So I think the answer is to talk to your geneticist. They are likely to be the best gatekeeper who will be able to link you up with your local expert IVF team, and would be able to explain to you what aspects you would need to pay for and what aspects are free.
Right. Great.
Someone asked about age. You know, I think in popular culture, we read a lot about advanced maternal age or geriatric maternal age over a certain age for women. Do risks for aortic complications increase if you are pregnant at a older age? What is that anymore? But if you are termed an older age pregnancy, is that higher risk for events?
So for most of us, if we say what's my lowest risk day to get pregnant, the answer is today, because the risks are going to, and that is unless you need surgery first or something, the risks will increase as we get older. So if your natural history with your aorta is that it's maybe getting enlarged, the risks are likely to be higher as we get older, but there isn't good evidence to say that dissection is necessarily increased in relation to age, but the risk of pregnancy certainly is. And I guess the answer really to all women is that when it's the right time for you, that's a good time to go. And delaying just for the sake of it is not necessarily in the interests of our health or that of our babies. That's a very general statement to make, and it doesn't come with any push or opinion, but it's just a physical fact.
Mm-hmm.
Yeah, I would just add to, like, on top of that age, I totally agree, is like sometimes as we get older, we have a little bit more musculoskeletal pain, and taking care of a newborn could be a bit more taxing. And so that might be unrelated to Marfan or these conditions. It might be if you have a lot of musculoskeletal concerns. So, having a baby is just hard work. And so think about also not the vascular health, but the health of your musculoskeletal system.
Mm-hmm.
Yeah, there's a question here from someone with actor 2 who dissected at 39 mm postpartum. Her daughter now is 13 years old and is at 38 mm aortic size. So she's asking, what is the daughter's risk at present?
I think that's one that needs to be answered by your daughter's physicians. Certainly there will be alarm bells being raised if you dissected at 39 millimeters, but that's a very specific question that I think really does need to be seen by, that you need to ask specifically to your daughter's doctors, and make sure that your daughter's doctors know your own history.
Right.
Mm-hmm. Great.
That's right.
I know we're just at the hour here, so I'll try to fit one more in. And I know, Dr. Thorne, you answered this one, but I hear this constantly, so I want to say it on the video too. Someone asked, if you dissected during pregnancy, like it sounds like this person did, is it always, or is there a good chance it's genetic? Because she was under the impression that it was just due to her pregnancy or being stressed out. And if you both wouldn't mind what you would advise someone in that position to do, I think that is helpful information for people to hear who are watching this later.
So I answered that on the chat, Gretchen, so why don't you go first?
Oh, I didn't see your chat, but I would say that if you are a young person, and I would say if you're pursuing pregnancies, you're a young person and have a dissection, that is not quote unquote normal, and that you should see a geneticist and get that further evaluated.
100%. That's exactly what I said.
Yeah.
We shouldn't ever accept a young person's dissection as being normal. It always needs investigating, and I think that we're learning more the age cutoff at which we would refer to genetics has gone up and up and up, because we're realizing that so many of these are familial.
Yeah.
Right.
Yeah, and there's Elena Checky, who's a genetic counselor at UT Health with Dr. Milowitz, has done a study on doing genetic testing on women who dissected during pregnancy. And I don't want to quote the number, but they were able to find a genetic diagnosis in a large percent of women who have dissected during pregnancy. So definitely please pursue that if that's your position out there.
Yes, and I think there have been so many questions on inheriting the condition. So I just want to put it out there. If parents don't have a condition, can the children get an aortic or a genetic aortic condition? I think the question is more, does it skip a generation? Would Gretchen say something to that?
Yeah, so usually we do, we don't usually see it skipping a generation. It's a little hard to interpret because sometimes you can have families where, you know, a grandparent has a dissection, a parent has a normal aorta, and then a grandkid has a big aorta or a dissection where it can appear to skip a generation, but it's what's called variable penetrance. So sometimes you can see how it presents in generations differently. However, you can also, in many cases of genetic aortopathies are like this, sometimes you can have a new spontaneous gene variant happen when the egg and the sperm come together that no one, you know, smoking or drinking or exercising doesn't cause those to happen, but spontaneous gene changes happen in all of us. It just depends where it happens.
Right.
We're not at the point where anyone is like doing exome sequencing on babies just to see the random things that have happened. So, you know, those random things without a family history do happen.
Yeah. And if both parents have the gene mutation, does that increase the risk of is it still a 50-50 chance of getting the condition? So it's a higher risk.
Yes.
Go
ahead. Well,
if both parents have a genetic mutation, whether it's the same one or a slightly different one, then there's a 1 in 4 chance that the baby inherits 2 normal genes, a 1 in 4 chance that the baby inherits both the abnormal variants, which could be have a particularly bad outcome, and a 1 in 2 chance that the baby inherits one of those. So you have a 1 in 4 chance that the baby is normal, a 1 in 2 chance of, as we've been discussing, one of the conditions, and a 1 in 4 chance of the baby inheriting both of the abnormal genes, which could have a very bad outcome depending on what the combination is.
Yeah.
There's a question about whether a father having ACTA2. Has anybody answered that?
I don't believe so. Please.
Okay, so there's a question that says, if the father has ACTA2, is there an additional risk on the mother or on the baby during pregnancy? So there's no additional risk on the mother, but there is a 50% risk that the baby would inherit the ACTA2. But there's no risk to mum.
Thank you for bringing that one up. There was someone who had written in early and asked, you know, aside from the mom carrying the baby's risk, is there a chance for, I can't remember exactly what the wording, and I don't want to take time looking it up here, but you know, that the child could be low birth weight or have developmental problems, not related to their own aorta, but is the pregnancy perhaps at risk of developing properly because of their condition?
So I lost connection there a little bit, but I think you said, does having one of these variations affect the pregnancy itself? Is that the question?
Yes.
That's a very good question, and I think for the majority, in the most of the time, the answer to that is no. The only time that I would say maybe there could be an issue would be with vascular, if the mother has vascular Ehlers-Danlos loss, and that's because the if you like, the womb is weak, so it's at risk of there's a risk of rupture. But the way the pregnancy itself develops, we wouldn't expect that to be affected by one of these genetic variations.
Well, we are quite over the hour, so I know you are both very busy, and we should let you go. We have more questions here. I'm sorry if we did not get to you, but please feel free to reach out to Chrisanne or I by email, and we will do our best to direct you to the right spot or get an answer from an appropriate expert. Thank you for attending so much. And this was obviously recorded, so it'll be available for viewing later. Any parting words from you, Chrisanne?
Well, I just want to thank Gretchen and Dr. Thorne again. This was very informational, and I think we'll be coming back to you with some questions
Yes.
From our community for sure, because this was a topic of much interest, and I'm so glad that you were here to address so much of information for it. Thank you so much. And of course, I'll be going back to look at the recording, so I recommend that, you know, people who have watched it today as well to go back and watch the recording to just learn more and make sure you understand what was presented today. Thank you so much.
Thank you.